Constipation. Key points. Constipation is a common condition and functional constipation is the most common cause. The diagnosis is made clinically. Internal examination and X-ray are not required. Symptoms of constipation are underreported. Medications are often required and should be titrated to achieve one, soft, easy to pass bowel action per day. Treatment is usually required for several months and if stopped early, may lead to recurrence. Background. Constipation affects 1/3 of children and frequently occurs during the introduction of solid foods, toilet training, and school. Most children defecate at least every 2-3 days, however breastfed babies may defecate as infrequently as once per week. Healthy infants, and LT 6 months, can strain and cry before passing soft stools, dyschezia. Unless the stools are also hard, this is not constipation and will self-resolve. Young children may ignore the urge to defecate, causing a build-up of large hard bowel actions. When this leads to painful defecation, it may cause apprehension, stool retention, and passage of further hard stool, a cycle of withholding and constipation. Assessment. History. Duration of symptoms. Stool frequency and consistency, see Bristol stool chart. Blood on wiping and / or in the nappy, may indicate anal fissure or organic cause. Mucus in the stool. Painful or frightening precipitant prior to the onset of constipation. This is different from infant dyschezia. Toilet refusal or withholding behaviors, e.g. crossing legs. Past medication use and effectiveness. Feeding history, e.g. food avoidance or force feeding, daily fluid consumption, excessive cow milk consumption. Fecal, soiling, or urinary incontinence, onset, frequency of episodes and relationship to bowel actions. Family history of coeliac disease or hypothyroidism. Asterisk note that children with autism spectrum disorders and attention deficit / hyperactive disorder have an increased risk of functional constipation. Rome 4 criteria, diagnostic criteria for functional constipation. Must include greater than or equal to 2 criteria for at least 1 month in infants or 2 months in older children. Less than or equal to 2 stools / week. History of retentive posturing or excessive volitional stool retention, i.e. withholding or incomplete evacuation. History of painful or hard bowel movements. History of large diameter stools. Presence of a large fecal mass in the rectum. In toilet-trained children, the following additional criteria may be used. At least 1 episode per week of soiling / incontinence after the acquisition of toileting skills. Red flags. Infants presenting, and LT 6 weeks of age, should be discussed with a senior doctor. Delayed passage of meconium. Most infants pass meconium in the first 24 hours of life. Consider Hirschsprung disease or anorectal malformation. Ribbon-like stools. Consider anorectal malformation. Weight loss / poor growth. Persistent vomiting. Abdominal mass, not consistent with large fecal mass. Organic causes of constipation. Medical. Coeliac disease. Hypothyroidism. Hypercalcemia. Slow transit constipation. Neurological disorders. Surgical. Hirschsprung disease. Meconium ileus. Anatomic malformations of anus. Spinal cord abnormalities. Examination. Abdomen. Palpable faces, often felt in the left lower quadrant but may extend across the right side of the abdomen. Lower back / spine. Consider occult spinal dysraphism / tethered cord. Neurology. Assessment of lower limbs, observation of gait. Perianal area fissures, placement of anus, anal wink / tone, or other abnormalities. Internal examination should not be performed without first consulting a senior clinician. Impaction. Hard mass in the lower abdomen and soiling from overflow. Management. Investigations. Investigations are not routinely required. If constipation persists despite adequate behavior modification and laxative therapy, consider investigating for less common conditions as listed above. Treatment. Behavior modifications. Position footstool to ensure knees are higher than hips. Lean forward and put elbows on knees. A toilet ring should be placed over the toilet seat if needed. Toilet sits up to 5 minutes, 3 times a day, preferably after meals. A timer in the bathroom can help. Encourage child to bulge out their abdomen. Praise child for sitting on toilet. Ensure toileting remains a positive experience. Chart or diary to reinforce positive behavior and record frequency of bowel actions. Encourage children to exercise more. Review toilet access, e.g. investigate barriers to using school toilets. Delay toilet training attempts until child is painlessly passing soft stool. Dietary modification. Excessive cow milk intake may result in inadequate dietary fiber. This may exacerbate constipation in some children. More information can be found here. Increasing dietary fiber is not an adequate treatment for constipation. Blank. Medications. See also appendix below. Osmotic and lubricant laxatives are usually required on a long-term basis, months to years. Reassure parents that this is safe and doesn't produce a lazy bowel. Titrate medication aiming for one soft, easy-to-pass bowel action per day. A common cause of recurrence is stopping laxatives too early. First-line treatment options. See appendix for oral laxatives. Infants and LT 1 month, Colixil drops. Infants 1-12 months, ISO osmotic laxative, Movicol Junior trademark or lactulose. Children, ISO osmotic laxative or lubricant, paraffin oil. Children with stool withholding behaviors, pain while defecating or rectal bleeding or fissures may benefit from inpatient disimpaction management. Rectal medications. Rectal treatment with suppositories or enemas should be avoided. Anal fissures can be treated with topical petroleum jelly to provide pain relief. Disimpaction. Children with severe constipation benefit from a disimpaction regimen before maintenance treatment begins. Oral medication as an outpatient is effective and preferred. Switch to maintenance therapy immediately post-disimpaction. Only consider the use of glycerin suppository or microlax trademark enema as a one-off treatment. Sedation should be strongly considered. Outpatient disimpaction management oral. The number of sachets or scoops to be taken daily for disimpaction are listed below. They can be mixed in liquid and kept in the fridge to be taken across the day. It is recommended to review ongoing need for disimpaction on day 4 of treatment. Number of Movicol trademark sachets using. Full strength. Adult Movicol trademark. Asterisk note, use double the dose if using Movicol trademark junior sachets, i.e. 1 Movicol trademark sachet equals 2 Movicol trademark junior or half sachets. Number of Osmolax. Small scoops. 8.5 g. Inpatient disimpaction management. Macrogol/electrolyte solutions, lightly trademark, glycoprep trademark, 13L/day, via NGT at a rate of 25 ml/kg/hr, maximum rate 400 ml/hr, or less, depending on pump used. Normal maintenance oral fluids should be given in addition to maintain hydration. These solutions provide no net fluid input and there is a risk of dehydration. For older children who refuse a nasogastric tube or prefer oral treatment, fixed-dose sodium picosulfate preparations can be used. Picolax trademark/Picoprep trademark. Children 4 to 9 yo. 1 sachet first dose/1 half sachet, second dose, equals 15 mg sodium picosulfate/day. Children and GT 9 yo. 1 sachet BD, equals 20 mg sodium picosulfate/day. Ensure adequate hydration to reduce the risk of dehydration and electrolyte disturbance, over 1 L recommended after a full sachet. Drink to thirst, Liquids should include a variety of fruit juice, soft drinks, sport drinks, etc. Oral medication taken during or within the hour before administration of a bowel washout may be flushed from the gastrointestinal tract without absorption. Do not use if signs of obstruction or in renal impairment. Consider ceasing if child begins passing clear fluid per rectum. Follow-up. Arrange follow-up with GP or pediatrician within 4 weeks. Consider referral to a continence or encapresis service for fecal/urinary incontinence, complex or difficult cases. Consider consultation with local pediatric team when red flags present, non-resolution occurs despite optimizing management over 6 months, outpatient. Outpatient disimpaction fails, requiring inpatient management. Appendix, medication information, maintenance phase. Trade name, Actilax trademark. Lactulose, osmotic laxative. Colixil trademark drops. Polazamer, stool softener. Movicol trademark, Macrogol 3350, electrolytes. Isoosmotic laxative. Osmolax trademark, Clearlax trademark, Macrogol 3350, isoosmotic laxative. Parachoc trademark, chocolate. Agarol trademark, vanilla. Plain paraffin oil. Paraffin oil, stool softener / lubricant. Dulcolax trademark drops or tablets.